Good evening, all of you. And I will introduce myself. I am Bhaskar Narayan. I am the founder member of the Telemedicine Society of India, and my tag says immediate past president. We have this session is on global telehealth. I think we have 4 speakers here, each of them describing the telehealth systems in their own country. We have people from US, South Africa, Pakistan and Abu Dhabi. My co-chair is Lord Nigel Christian, and you know him, he is the guest of honor today. And if you are ready, we will start with the first speaker.
Well, good afternoon, everyone. I'm Dale Alverson, and I'm the immediate past president also. Not so important when you're the immediate past president, but of the American Telemedicine Association. And I'm the medical director of the Center for Telehealth and Cyber Medicine Research at the University of New Mexico. And just so you know, I'm also a pediatrician, but I'm totally now focused on how we use telemedicine e-health, not only locally, but also globally. So I'd like to talk to you this afternoon as one of the speakers about international telemedicine and e-health and transforming systems of care in the global community. Now, some of you may have seen my talks before, but right now, I believe we're in a perfect storm. And what does that mean? Well, if you look at our country, but I think in the United States, but if you look around the world, we're in a period of the need for massive healthcare reform. It was talked about this morning, and we're moving from outside the pilot to how do we actually do this. In the United States, we have President Obama's Patient Protection Affordable Care Act, which is highly controversial. If you don't know, it's very partisan. But everybody, whether you're Republican or Democrat, independent in our country, has stated that we must change our system. We can't afford the spiraling upward costs. We're one of those countries that spends more money. And Lord, Nigel, you talked this morning about the disparities that we have in the amount of money we put in, but the outcomes are no better. And if you look in the United States, our outcomes are no better and very often are not as good as many other countries. And then facing this perfect storm is economic downturn. It's forcing everyone to look at ways that we can face these healthcare problems in a more collaborative way. We have the need for more access to care. What we're saying in our country, just like you're saying in India, that everyone should have a right to access to appropriate care, regardless of where they live, or their economic status, their age. And look at the aging population. People are living longer. In the United States, we have the baby boomers from the end of World War II that are now in our what's called Medicare, our social healthcare system. We have a critical shortage of healthcare providers in our country, a shortage not only of physicians, specialty, and primary care, but also primary care. And it's not just physicians, it's nurses, it's pharmacists, it's mental health workers and counselors. We have the pressure to adopt electronic health records and health information exchange faced worldwide. The whole idea of defining meaningful use. How do we do this in a meaningful way that really has a positive impact? We have the patient-centered medical home concept, which you've heard about today as well. And then something that's called accountable care organizations, where you should get paid on the basis of performance. And with that then is these emerging enabling information communication technologies that we've been hearing about and will continue to hear about. So I believe this is the time, a time never before, a time for telemedicine and health information technologies during this perfect storm. And I believe these technologies can help us navigate the perfect storm. And we're hearing that. We're hearing about applications that can use a broad spectrum of information communication technologies. It's not just video conferencing. It's using the web. It's using the internet. It's using health information, using transfer of images and looking at remote monitoring. Then we can have more effective distribution of these limited resources and expertise. We can increase access to care. And we can bring care to the patient as we say, aging in place. And we can decrease these unnecessary variations in care and improve continuity and coordination of care using this concept of the patient-centered medical home. Avoid unnecessary hospitalizations and duplication of tests, and thus the bottom line, improve health outcomes, and if we really want to get to the bottom line, is reduce costs. So I mentioned that telehealth and e-health is a spectrum of information communication technologies. It can be synchronous. It can be asynchronous, what we call store and forward, capturing images and sending it to an expert for interpretation. It can use, indeed, video conferencing when it adds value. It can use the web and web portals that we've been hearing about. It will use mobile devices, the mobile phones, smartphones, and tablets. We're seeing it happen already. And simple aspects of using our communication devices, CMS, text messaging. And I believe even on the advanced side, geospatial information systems, where we can superimpose health data on maps and better visualize the distribution of health issues, whether they're chronic disease or it's pandemic flu that we watch dynamically, that allow us to have better consequence management and better situational awareness. And then I believe very strongly that we must integrate electronic health records and health information exchange if we're going to make these technologies effective, whether it's telemedicine, as we typically think of it, or e-health in general. You've already heard we're going to see more and more the use of handheld devices, what's called mHealth, which we've been hearing about, the use of smartphones, and of course the use of the tablets. This is from the Chicago Sun-Times. An ER physician pulling up an image, and also could pull up health information, share it with the patient, explain why they're doing a certain treatment to get the patient engaged. And I think these mobile devices will play a very important role as we look at telemedicine globally as well as locally. I want to mention a couple things, and that is, what does this all mean when we talk about global health? And global health research is an opportunity that we can use in telemedicine. Think about addressing the United Nations Millennium Development Goals, and I think particularly as a pediatrician about Millennium Goal number 4, reducing child mortality by 2/3. And we don't have a lot of time left, do we? 2015, we want to reduce the under 5 mortality rate by 2/3. We have a long way to go, but each step of the way, as we use these technologies, I think we can address it. Number 5, improve maternal health, reduce by 3/4 by 2015 the maternal mortality ratio. And there are programs like Mama's Net at the University of Washington in Seattle that are looking at how do we deploy information technologies that help the community health worker. And in Latin America and Spain, promotores de salud, how do we help them provide care at the local level that can reduce maternal mortality? And we know that some very simple things can be done, even with postpartum hemorrhage, that can reduce mortality in women without even access to blood products. And then, of course, goal number 6, combating HIV/AIDS, malaria, and other diseases, have them halted by 2015 and have begun to reverse the spread of HIV/AIDS, the incidence of malaria that kills over 1 million people a year, most of them children, and other major diseases. I believe in global health research and telemedicine we can use a variety of approaches. Knowledge, attitudes, beliefs, and behaviors research, what's called CAB research. Field studies, applied research, health and disease specific, that's already happening globally. In Uganda, Johns Hopkins has a program using smartphones to track patients with HIV/AIDS co-infected with TB and know where they are. Because quite frankly, in a developing country, just like in New Mexico, in Indian country, there are no addresses. But we can find you through GPS. We know where you are, and we can help you get access to care. And I mentioned geospatial information systems in that regard. And then, of course, we've already heard hand in hand many times, right with the clinical applications and consultation, is education and training programs. I spoke earlier this afternoon about Project ECHO, where specialists are helping primary care providers through case review. They don't see the patient directly, but help the primary care provider learn how to treat complex chronic diseases like hepatitis C, and then are available if the patient's having complications. And then the application of mobile health and cell phones, all these deserve research. We need to evaluate the real impact that they're having. Now, international telemedicine e-health is transforming, I believe already, systems of care in the global community. And why do we do that? Many times, even in my own state, they say, we have enough problems here locally. Why are you working in India or in South America or Africa? Because most health issues are global. No longer can we say that's that country's problem. It's all of our problem. And I snapped this picture actually from one of my visits in India, actually in New Delhi, on a cover of a book. And I think it's important for us to really recognize that the earth is but one country and mankind its citizens. We need to work together in the global community to have an impact on people around the world. We're basically all made the same. We come from various cultural backgrounds, religious backgrounds, and experiences, but we face similar problems. This is a picture I snapped in Nepal, in Dhulakel, outside of Kathmandu. This is at a hospital in the foothills of the Himalayas, where home deliveries were the standard. But now they're identifying women who are at high risk, encouraging them to deliver at the hospital. So this is at the hospital. This is a newborn, and the newborn little girl is getting her first bath by a student nurse. And that baby is doing what all babies do, or most babies do when they get their first bath. They cry out loud. But that baby is not crying in Nepalese. It doesn't cry in any Indian dialect, doesn't cry in English, doesn't cry in Chinese. That baby, she cries a universal language. And I think it's symbolic of the fact that we can work together in the global community in a meaningful way. Issues like H1N1, the swine flu, was no longer just one country's problem. It was a worldwide problem. And I believe telemedicine can improve not only our situational awareness of the spread of disease, but also in our mitigation of that spread. That situational awareness, thus consequence management in a meaningful way that must be global. And right on the heels of H1N1 is the fear that the avian flu, H5N1, will sooner or later mutate to human transmission. And if that happens, this is an extremely deadly virus. If that happens, we will clearly have another worldwide pandemic flu on our hands that I believe telemedicine can play a role in mitigating in a way that we couldn't do in the early 1900s. This is a picture I snapped in the jungles of Ecuador in a small hospital in Lago Agrio. And definitely there are problems that are unique to tropical areas, dengue, paludismo, malaria. But right up there, and I talked about this earlier this afternoon, hepatitis C. So here I'm thinking, gosh, it's an issue in New Mexico that we're trying to address. It is recognized as a problem in the jungles of Ecuador. And what you see is another sign in Quechua, the native tongue in that area, is tuberculosis. Recognizing we need to address tuberculosis in a meaningful way. And as I've often said, I've been traveling, and that's one thing for a much more mobile society. So if I start coughing, you might want to back up, because I was just in Zumbawa, where they say at least 1/3 of the population has of active tuberculosis and not treated. Now we have systems in place where we can actually, what they call peering points, where in our country we can peer all over the world through the internet. And it's two-way. It's not just one way. When I come here to these meetings like in India, I learn something about what you're doing in your country that I could actually transport over to what we try to do in our country and vice versa. We can teach each other and learn from each other in meaningful applications of these technologies. In Ecuador, it's their country's network. We've worked in Ecuador for some time with the Ministry of Public Health and a university in Quito, Universidad Tecnológica Econocial, and they developed their own network. It's a satellite network, actually working with the Ecuadorian Air Force, not the United States. It is their network, and they're connecting their medical centers to smaller community hospitals in their country. So, for instance, from the University Tecnológica Econocial, UTE, they connect to the Islas Galapagos, the Galapagos Islands, in a hospital in San Cristobal. doing consultation and support of the local primary care providers. And into the jungle, in El Oriente de Ecuador, in La Selva, in the jungle, in Nuevo Rocafuerte, on the Rio Napo, near the Peruvian border, using these satellite networks. That is their country's network. In fact, most of the consultation occurs from Quito, and other primary care physicians can take advantage of local specialty care. And quite frankly, we're not providing consultations to Ecuador. We do, though, share these networks for our students and for our faculty to learn from each other. I'd like to show this. Some of you may have seen this before. On the Rio Napo, they have a floating clinic, La Lancha Medica, and we went down to inspect it after it was delivered. And we were in a pickup truck, and we drove down to the bank of the river in the jungle, and that gentleman jumped in and got behind the steering wheel. And I like to point it out because, one, it shows we're really in the jungle. And the other thing is, I don't know how many of you have been face-to-face with a monkey, but they don't smile and they have teeth. And they're pretty aggressive. So I jumped out of the truck. Well, I snapped this picture. This is Dr. Ricardo Dago, who's a cardiologist and the Dean of Health Sciences at the University in Quito with whom we're working. And he wasn't afraid of the monkey. He took a pen out of his pocket, reached in the truck, the monkey wanted the pen, and pulled him out. So I snapped that picture. I said, well, that's interesting. Because the next question you get, well, you're in the jungle, and that's really nice that you're trying to deliver care to the local villages. And then I snapped this picture almost immediately thereafter. We're getting in the boat to go, in the small boat to go inspect the floating clinic. And what's he doing? He's on his cell phone. He's talking to his office in Quito, hundreds of miles away. And the point of this is, you can be in the jungle in a remote area, but the technology is penetrating in ways that we never could before. In Nepal, I've been amazed by the work they've done in Nepal. And they're connected to you here in India, looking for expertise. And they have a high-speed backbone with internet too. They're now connected to the Asian Pacific Advanced Network. They can connect anywhere in the world. And what I've been amazed at what they've done with wireless networks. They put up grid antennas for this wireless network anywhere they can. Whether it's putting up a pole so they get line of sight or on a tree. And they're right up to the base camp at Mount Everest with these technologies now. And they've done this themselves with the help of consultation with countries like India, the United States, and the UK, etc. So now they have networks that get through the mountain passes to villages that never could be reached before. In India, this is my third trip, and hopefully there'll be many more to come because I learned so much when I come here. This is in a hospital in Rajkot, Saurashtra University, and a hospital that they support. That's a child there that had severe malarial anemia and almost died, hemoglobin of 4, and they treated the patient. And that person, looking at the medical record with a medical resident at the children's ward, is a specialist in severe malaria of anemia, works in Kenya for the most part, but is on faculty at our university in New Mexico. So we have ways now using the technology we could share that information and knowledge with each other. And there's Dr. DJ Perkins, the malaria specialist, because what he's surrounded by is what makes this all meaningful, is how do we reach children, how do we reach families in a meaningful way. And then I'll close with this, and that's the recognition of traditional medicine. We work with curanderas and curanderos de salud in our Latin American countries, and we work with shaman. We have what typically have been called medicine men in New Mexico, promotores de salud, and studying there's in Rajkot and Saurashtra University, trying to understand what's in these herbs and plants that has the medicinal qualities that have been going on for thousands of years. I also want to close with mentioning the Swinfin Charitable Trust, using a very simple web-based solution. If you can connect to the internet, a referring physician can send data, including images. That's then distributed through a web portal to specialists who volunteer and can give a response back. This is an example of a child with a congenital skin disorder born in Baghdad. And of course, probably the last place a lot of us would want to be, at least at the time of these conflicts. And yet, virtually, the data was sent about this newborn baby. We saw the pictures. We could share this with pediatric dermatologists very quickly, had a diagnosis and treatment plan that went back to that pediatrician in Baghdad. I can't finish without mentioning the American Telemedicine Association, of which I'm the immediate past president. We'd like to see more countries involved. We signed a memorandum of understanding with the Telemedicine Society of India just this past year. We have several other countries that have signed on, and we're looking at how do we work within the international community. And you've got the International Society of e-health and telehealth here, Frank Levens. How do we work together in a global community in a meaningful way? No one has to be in control. We're the American Telemedicine Association, but we need to work with other countries and have those affiliations, because through these systems we can share knowledge and experience, but we can put it in a realistic context. What can you realistically do with this technology in a given country, developing country, based on their available resources? And Dr. Maurice Mars has pointed out that there's a lot more than just deploying the technology. It's addressing the workforce, the lack of education, and understanding how we can use this in a way that meets mutual needs and interests and apply the most appropriate technologies. So in closing, the next steps, I believe, are to develop concrete programs where telehealth adds value and mutual benefit in a realistic, appropriate manner, utilize emerging new information communication technologies that can provide systems for global connected health and cultural exchange. We have opportunities to integrate telehealth in a manner that can provide platforms for greater continuity and collaborative efforts between countries and within countries for clinical service and consultation, public health, education and training, and research. Because if you look at that last picture, that is what it's all about, is how do we reach that child, that mother, that family in a meaningful way. We think globally, but we have to act locally. Thank you very much.
Any questions for Dr. Day?
Thank you.